All right, welcome back. If you're just joining us, you are just in time for the conversation we're about to have today. That's around the health insurance debate, understanding health insurance. Do I need to get it? Why? And which one is best, private or public? We'll get into that. Allow me to reintroduce the panel that is with us here. We have Dr. Elizabeth Wallam. She is the Program Director for the Health System Strengthening. That is at AMREF. And sitting closer to her, Dr. Alex Muturi, KMPDU Trustee. And on my other side, I have Dr. James Nyikal, Member of Parliament for Seme. He also sits within the Member Health Committee. And next to Dr. James, I have Michael Njau. He's the NHIF Manager for the Thika branch. Michael Njau, let me begin with you. Are Kenyans attentive? Are Kenyans intentional in terms of habit when it comes to getting medical insurance?
Thank you very much. I think as Kenyans, what the trend has become is that people mitigate on the health issues when they have problems. We want to make a dramatic shift from this scenario. We want people to be having insurance. And that is why we are advocating on the issue of NHIF. Let every member, every Kenyan citizen, to have an NHIF, so that in case they have issues of health, they're able to access the benefit. And we are saying this. Why is this NHIF? There are some three criteria why you're saying NHIF. Because number one, it is the issue of affordability is there. Because the rates, the premium are quite affordable to the common mwananchi. Then the issue of accessibility. Go to any town, any locality, you'll find a facility that is accredited with NHIF. Then we are looking at what are these requirements that mwananchi, that Wanjiku, that Mamamboga requires for us, for him or her to get an NHIF card. They are simple things, because we just require the copies of the ID for that person. And for the spouse, the copy of the ID. For the children, it's about the birth notification and the birth certificate. So we are making it, we are breaking down insurance to be in the simplest form possible. And also, a key thing that people, Kenyans, tend to shy away from, when you hear about insurance, there are those issues of the medical checkup.
Right.
You know, people think, what I don't know, does not concern me. So many people, even Daktari, I don't think the last time that you went for a medical checkup, people just assume, what is in my body, I don't want to disturb it. So with NHIF, we don't subject our members to a medical checkup. The other beauty, we don't have age limit. So I can take an NHIF insurance for my grandmother at the village. So we are saying, let us not take insurance when you have the problem. Let us be having an insurance cover for ourselves.
Do you genuinely believe that NHIF is Kenya's way when it comes into achieving universal health care?
The Kenyan way. Why? The cover is a family-based cover. For example, what you are giving people in the informal sector, it's a cover of a premium of 500 shillings a month. Translating to 6,000 shillings in a year. 500, you say? 500 shillings in a month. Okay. Translating to 6,000 shillings in a year. Right. And if you look at the range of benefit that this person is going to get, it's quite huge. And remember, that premium is covering for that family. It might be the husband, the spouse, and maybe 6 or even 7 children. The average family numbers in Kenya are 6. I don't think there's anywhere you can get a cover of 7 people in insurance premium that is catering for only 500 shillings. If you do math, it's somebody has been insured for 70 shillings. And for a wide range of services to be offered.
Dr. Nyikal, from your perspective, where do the gaps lie? Because we've seen a bit of complaints when it comes to NHIF clearance time and the amount of what they cover when it comes to medical bills.
You see, when you're having this discussion, you must distinguish between administrative issues and principle and policy issues. Now, what you are saying is the payment time and sometimes not paying, those are administrative. They do not make a principle bad. That's just to improve the administration. I am sure NHIF still has a long way to go, and it has tried to improve its administration so that the claims are quick, nobody is denied any payment, and so on. Then when we go to the principle of insurance, from her question, are Kenyans keen on insurance? First of all, we must teach our people what is the concept of insurance. Is sharing risk. And you say, I'm taking this, if it happens, then I'm covered. If it doesn't happen, it's okay. But what the problem we have with men in our country today, when you say you are covered for this much, people think you are entitled for that much for the year. You are not entitled for that much. You are entitled for that much if it happens. So you get into problems of even people saying, I've paid for 5 years and I've not even gotten sick once. So why should I pay? But that is the exact basis that while you didn't get sick, somebody else got sick. So your little money plus the little money for other people who would get sick, paid him. The day you get sick, the other people who didn't get sick pay for you. So if that concept is understood, then we really must train our people on insurance.
So let's help Kenyans understand the foundation of how insurance works. So I make a monthly stipend, a monthly contribution. Let's say for the next 5 years I don't get sick. Am I entitled to that money?
You know, I need to come in and support my good friend here. The spread of risk. We are saying the premium is 500 shillings. And we are saying you register with NHIF. Then automatically you don't get to access benefit. If you register today with the 500 shillings, you don't get to access benefit now. There's a grace period of 60 days. Okay? After 60 days, us as the NHIF, we are mandated to cover you for your medical bills. Take a scenario on this spread of risk. This person has paid 1,500. That's a premium for 3 months. The card you take 60 days to mature. On the 61 days, it matures. Then this person need to access benefit like maternity package.
Right. Or
a cesarean section. We are not going to say, since you've only paid us 1,500 shillings, and the maternity package that you are paying is 30,000 shillings, we are not going to pay for you. It is a question of pulling the resources and spreading the risk. So we urge Kenyans, we do not, the issue of insurance, you even also you don't insure your car to go and crash. So you don't take insurance to benefit from it. It is harder when that issue, that need arises.
Let me make it simpler. We all insure cars, and we can go for many, many years without an accident. Do we now say, those years have paid, I want my money back? The same goes for health insurance. In fact, if we were to go to social health insurance where everybody is sick, the less people get sick, the better. So that then you want to put insurance to treat people when they're sick. But you also want to put measures that stop people from getting sick, so that the little money you have that you have pulled can now go a long way. So that is the concept that even in the private sector, people will think it's only NHIF. Even in the private sector, there's a lot of problem of fraud related to people thinking, I'm entitled to 100,000, now the year is ending, I haven't, can I get a provider so that we get out this 100,000? Then you kill the whole concept of insurance. Because when a company say has 100 people, and then they say we are insuring each person for 100,000, that is probably 10 million. Now, if all those people get sick, the insurance collapses. It is assumed on actuarial studies that if you insure 100, probably only 5 will get sick in a year. So that is such a critical point that people should know. Again, we must educate our people that insurance is less. Because in this country, we pay more for funerals than we contribute to treat sick people. So in the end, we still use the money. Why won't we put it in insurance?
Hold that thought in just a bit. We have a caller from Mombasa. Mary, good morning.
Good morning to you.
Yes, go ahead with your comment or question, Mary.
Yeah, I just want to find out what is the hell going on with Kenya nowadays. In the time of Kenyatta, we were paying only 20 bob in the post office. I used to take all my family to Mombasa to the Catherine Baby Hospital, and we never used to pay not even a penny. Now, we pay 500 shillings every month, and then you go to Pandia or you go to Aga Khan, they don't accept your card. So what's going on? You know, what's going on in this country?
Okay.
You know, because now I think there's a lot of problems. The people that are sleeping on their job.
Okay.
Because if we are paying insurance and still they can't cover us when we want to go to the hospital, what's the use of paying it?
Okay. All right, Mary. That's Mary from Mombasa, and you will answer that in just a bit, because she's wondering why is there certain hospitals that don't accept that card. But before we come to that response to Mary, Muturi, where do you think the gaps lie? I know you've been dealing with both NHIF and patients as well. What can be fixed to make it even better?
I think to start off, NHIF has grown tremendously from where it was 5-7 years ago, and in terms of even the service range and the benefits they're able to offer their patients. It's very, very encouraging when you see the cardiac patients, the spine patients, the patients with brain tumors who are able to comprehensively get covered by the social insurance. Because people can't pretend to have a brain condition. It's either you have it or not. So it's one of the areas where people actually consume when they need to, as opposed to when people rush to utilize their premiums last minute. So in that aspect, they have done very well. They are also involved in education in terms of prevention. And I think, for me, the gap still lies with administrative issues. The length of time it takes to process claims and to verify misclassification of diseases that ends up getting someone not covered. Mm-hmm. For example, if you call a condition cosmetic, the insurance or the insurer regards that condition as cosmetic. And as a healthcare provider, I know it's not cosmetic. It's either what we call reconstruction. We are trying to get you back to function or to an acceptable form, which was not there because of disease or because of accident. Mm-hmm. It's not cosmetic. Cosmetic is enhancement of what is already considered good. But you find that many insurance providers will quickly label a condition or a diagnosis as cosmetic to exclude someone from getting access. So I think there is a lot of work to be done in that area. We can help as healthcare providers because we understand what reconstruction means and what cosmesis means. Mm-hmm. So that people who are actually in dire need of reconstructive surgery, mm-hmm. Especially from trauma, from burns, from other diseases that end up disfiguring the body, can get that service without being excluded. Mm-hmm. The other area where maybe we need to improve is the reimbursement, the disparity between a private hospital and a public institution. Mm-hmm. I work in a public institution. I'm a surgeon in a public institution. The bulk of my work in recent days has actually ended up to be surgery for cancer, whether it's cancer of the breast, cancer of the colon, or cancer of the rectum. I'm finding that the bulk of my work is those three areas. And it's a very expensive condition sometimes to treat because of some of the things that are needed in terms of supplies. I'll give you an example. If you're doing surgery for rectal cancer, there are devices in surgery now we call stapling devices. For you to be able to complete that operation, the estimated total cost of those two gadgets that help you to remove the tumor and restore continuity of the gastrointestinal tract will cost almost 100,000 shillings. There is no insurance company in this country that is willing to cover that cost. Mm-hmm. They look at that as an extra. It's an inconvenience on their part, and yet it's something that is required to be able to offer someone the ideal care. I can tell you for sure, NHIF is not covering it, for example. It's one of the areas that I feel very frustrated because you're forced to actually tell the patient, now you have to dig into your pocket and get me these devices because without them, then we are actually endangering your care instead of offering you treatment. The other aspect, we have really pleaded with NHIF. I know some of the reimbursements they do are fairly standard for the public institutions, But we are telling them, we are increasingly finding that the conditions we are dealing with are no longer standard.
Right.
They need to revise some of the amounts they are giving. The surgical packages they have come up with for the private hospitals are very good because they are helping very many people, whether they're in informal sector or in employment, to be able to access care. We want the same considered, even if it's on a lesser scale, in the public institutions.
Let me rope in Dr. Elizabeth Wala. Earlier on, Michael Njau was talking about how perhaps even with as little as 500 Kenyan shillings contribution in a month, you can secure your own NHIF. But how many Kenyans can afford 500 per month? Because at the end of the day, statistics show only 2% of Kenyans, and this perhaps would be the middle class and the upper class, can actually afford private insurance.
Yeah, it's actually quite true. Our coverage rate for insurance, even for NHIF, it's around 17% for the social insurance and 2% for the private ones. So one of the principles of insurance is pooling resources. So you need numbers. And I think we need to have a stronger movement towards bringing people into the insurance pool. I don't know whether voluntary insurance is going to work because, again, our perception as Kenyans and generally I think Africans is that we're not risk prepared. So there are some attempts into looping in the informal sector. Some of them include, having a broken down system of getting the 500 shillings eventually at the end of the month. For example, we have a program where using the community health volunteers, they go door to door. So they take NHIF to the household because that's one of the impediments of, if I have to leave my house to go and look for an NHIF office, then I'd rather be doing something else. But if someone comes to me and breaks down what NHIF is all about, and then through the system I'm able to get 20 shillings into my account, 30 tomorrow, eventually the 500 accumulates. When you look at some of the studies that have been done, in terms of the household consumption, you'll find that there's quite an amount of money that revolves in the households. Someone will find 20 shillings to drink pusa every single day. You'll find Mama Mboga will get 100 shillings from the sales of the day. So if we just have a way of getting to the understanding or getting the people to understand that, okay, out of all this that you get, how can you break down that today you put aside a small amount every day? So the 500 is not very prohibitive at a go. And we piloted some of these schemes, like in Laikipia County, where the governor was looking at how do I come in as a county government to help bring up this indigent population, but they didn't have the data. And you just assume that 40% of my population is indigent. But when you go to the household, people have chicken, people have a goat here and there. So the poverty description is really not backed up by data. And using that system, we were able to, bring out that we reduced the number 40% to 20%, so that he's able to now cover the 20% because there is data. And now the other 20% have been able to pay because someone just broke it down into smaller amounts that they are able to cash on. Yeah. Another thing I wanted to say was I think we don't have a systems thinking in terms of how we approach our health issues. So, for example, you'll get, the media will run with one story and then we'll say, okay, let's now kill the doctor's professional fees, or rather reduce the doctor's professional fees. Tomorrow we'll say something else comes up and we'll be like, today we've seen it is about allowances. But when you approach health on a systems thinking, and for example, in the insurance sector, we don't use data to make decisions. I mean, like the calculations that he's talking about, they're actuaries who come together and you would look at the cost of healthcare in the private sector, in the public sector, justifying many of the discrepancies that are there, so that when you're developing a package, it is based on data, on information. We also don't have, we don't place responsibility on the consumer. So the consumer lacks information on even NHIF simply. I get so many questions saying, where can I go with this super cover? So the information is on the website, but the consumer is, maybe they don't access the internet or they don't go the step further to get that information. So you'll show up at a facility without prior recognizing that not all facilities are taking that particular cover. So let's put also responsibility on consumers to know what they're taking up, to know what covers them. They say the devil is in the details. Yeah. And if you don't have that, as a consumer, take it upon yourself to find out all these things. Also, as a consumer, take it upon yourself to develop better health-seeking behavior. Yeah. Don't wait for things until they're too late, because that's what is happening. Take upon yourself to go for screening exercises, just to know that some of these things are very easily prevented, rather than waiting until now it's an admission case.
All right. There's a lot of feedback coming through our SMS line 224222. Mr. Njah, I'll come to you. There were two questions raised towards you. Mary from Mombasa called and said that there are certain places her card cannot be accepted, and Dr. Muturi also bringing up issues to do with cosmetic, what is termed as cosmetic, and yet they know very well it's a medical procedure that is not necessarily cosmetic. And the other one that also comes up is pre-existing condition. And that is one term that is something that people have not defined yet. We'd like to know from you when we come back from the break. But for now, there's a lot of feedback coming through on SMS 224222. Let's read some of them. It doesn't leave a name, but it says NHIF is giving us a hard time. When someone is not near the hospital, that one is registered to be treated. Why don't they make it simple for us and pay fully even in private health facilities? Because in private hospitals, they only pay 2,400 per day. We'll find out if that is necessarily true from you.
All right, let's take a look at another SMS. 22422 is our SMS line, and you can be part of this conversation. You don't say your name, but you say, in terms of insurance, why do policies differ from teachers and civil servants, yet teachers pay more than civil servants in terms of premium, I believe. All right, so we'll get an answer to that question.
Civil servants and teachers pay more? Okay. Comment from Mildred. Says many Kenyans pray that universal health coverage that becomes a reality the soonest. Becoming sick has become too expensive, and coupled with greed for money, especially by private hospitals, worsens the situation. Recently, NHIF disputed a bill from a private hospital, and the hospital slashed the bill by almost half. What does this mean about their billing system? Billing system is a bit of a concern there. We'll talk about it as well. And I see Dr. Nyikal shaking his head. He will speak about the billing system as well. And we have a final one here in a language that Zinzi doesn't go for. Now, Liza, NHIF yangu iko na deni ya 11,000. Je, naweza ilipia na kuendelea na huduma ama hadi nifungue account nyingine? That is a question that Fatuma from Garissa is wondering. She has a bill. Can she fungua another one? Or what happens from there? Let's take a quick break. Yeah, we'll come back with those answers in just a bit.